Indeed, it's a very wide topic, and more justice would have been actually separated so that you talk of the colon cancer, rectal cancer, and anal cancer. But anyhow, we'll still try and do justice. Most people do talk of them as if they are a single entity, although they have certain similarities, but they also tend to be quite distinct. So maybe, of course, as you know, colorectal cancer is cancer of the large bowel. And maybe we start with the epidemiology. You see, I'm just trying to show you that is tumor in the rectum. I don't have a pointer, but that is the hepatic fracture. You can see the liver behind there. This is the cecum in the cervical colon, the splenic fracture, and that's a tumor in the rectal sigmoid. The global incidence, they say that it's about 1 million persons who are affected annually, and of this, there is 3/4 of them will die. So it's a tumor with a very high mortality. These figures may keep changing from year to year. If you check some given newer literature, they may talk of 1.3 million. As you know, also even in our own place here, we are diagnosing more of them. So this figure keeps rising every year. And the incidence is said to be higher in the Western or developed world, with high figures in Europe, in America, in Australia, in Asia, and lower figures in Africa. So the previous texts and literature will actually say Africa has very low figures. But now we are thinking the story is different. It's possibly that the diagnosis was not very accurate, but the figures are rising also. And it's a tumor which affects more men than women, sometimes in the ratio of 2 to 1. Now, in this slide, I showed you on the left the group of the tumors, the group of deaths, the number, the ranking of deaths from tumors. And number 1 has remained lung cancer in both male and female. And number 2 is gastric. Then liver and colorectal will be number 4. A few may put it as number 3, depending, but it's somewhere there, 3 or 4. The Kenyan scenario, according to some data I got from Congress, is that for the males, it's different for the females. So that for the males, the leading cause is actually prostate cancer. Then you have CA esophagus. And then we have the head and neck cancers. Then stomach comes number 4, and the colorectal or colon comes number 5. The rectal tumors generally tend to be fewer than colon cancers, but most of the times, like I say, taken together. Then for the females, the leading cause is breast cancer, followed by the cervix, stomach, and colon comes number 4. So it's still ranking very high, almost like the worldwide trend. Of course, this is now very different from what we used to, the data we used to have in pathology, where the skin would be number 1, then we have cervix. So indeed, the colon is coming higher. The figures when we were learning with Professor Cassidy was that colorectal would be somewhere number 7, number 8 there. So you can see it's really coming higher up. I also looked at the figures we have here of patients who have been treated for GI. I now concentrated on GI tumors and looked at figures from 2010 to 2016. And you can see the GI tumors. Among the GI tumors, colorectal was leading. There are 41 cases. And the stomach being not a distant second. Esophagus number 3. And there were no cases of small bowel tumor across all the years. This is not surprising because we know small bowel tumor is very rare. Although we do see it, but possibly maybe when you scope in a year, you may see 1 or 2. It's very rare. Now, this table shows data of a study I published 7 or so years ago, in which case I looked at patients presenting for endoscopy. And of this, when you look at the upper GI, out of about 8,600 cases, almost 10 of them had tumor. And lower GI, of course, the numbers often are lower for lower scopes than upper GI scopes. And the percentage not very far, 8.5%. So although we have a preponderance of upper GI tumors, but still the figures are not very far. Maybe 10% in upper GI symptoms will have a tumor, and almost 9% in lower GI presentations. The next slide showed of the upper GI tumors. Esophageal cancer in our setup is the leading cause, and this also goes to show this in keeping with the current Henry data. Upper GI tumors accounted for the patients with esophageal tumor accounted for 64% of upper GI tumors. So the ratio of the esophageal to gastric was about 2:1. Now, what are the risk factors? I would think this cuts across whether we are in the first world or the so-called third world where we are. And they mentioned really age as one of the leading risk factors, where especially age after 50, especially after 60. Although still in the literature they are saying that they are seeing tumor in progressively younger persons, even like we are witnessing. But by and large, generally speaking, is a tumor of age. Lifestyle also very high up. I'll mention about lifestyle later. And then number 3 is inflammatory bowel disease. And we know the two main ones, chronic disease and ulcerative colitis. Ulcerative colitis tends to have a higher predisposing risk than Crohn's disease, but both of them do. And then family history. I'll mention that. With family history and genetic disorders. In family history, they say that if you have a relative who has had a tumor of the breast, tumor of the prostate, then the chance of if it's a first degree relative, then the risk of another member in the family getting it rises by about twice compared to the general population. So it's something we do not, family history of cancer. And we should now, especially with the seeming exposure, maybe when you take history, we inquire about the family history of CA. Genetic disorders, and I'll mention this soon. Lifestyle, obesity has been consistently shown in many studies and meta-analysis to be a predisposer. And of course, obesity is like a metabolic syndrome, so metabolism and so on plays a great role. Possibly, in the African Americans, for example, or in people who migrate to the US and adopt the lifestyle there and become like the Native Americans, they also take up the same incidence. So that is thought to be one of the biggest factors. Smoking, like in many cancers, GI cancers, is a prime risk factor. Diet has many things. Alcohol goes without saying, it's been shown in many studies again to be a predisposer, and especially when it's dependent on the intake, the degree of intake, so that the more one takes more than 1 or 2 beers, then the risk rises more. On the other aspects of diet, what has been consistently shown in studies is the issue of processed meats. I know there has been an alarm recently about the issue of red meat, and it was, when studies delved into it more, it was not where the processing was higher, then that increased the incidence. What about issues like fiber? Initially, because of the so-called low figures in Africa and our diet, it was not that fiber is the one single factor which was helping us. But other studies have really looked at the issue of fiber, and they have not been able to consistently show, even in cohort studies, that indeed it makes a big difference. However, what they say is that when you look at the overall factors, those people who take higher fiber are also likely to have less of the other predisposing factors. As you know, CA is a multifactorial thing. So fiber may not be a single predisposing risk factor when it's less, but it's likely to be the people who take more fiber, more fruits, more vegetables, also have other less risky habits or lifestyles. Other things in the diet which have been shown to be useful include, for example, folate. In the US, they fortify their food with folate, like the way we fortify with salt, with iodine. So it's been found to be useful. Other things like calcium has been shown to be useful. So there are many factors. Now, lifestyle, again, sedentary lifestyle has also been shown in studies to be a contributing factor. Genetic we mentioned, and although I'll show later a table of showing the contribution of the various factors to the risk of developing CA, there have been two main genetic diseases which have been shown to be actually predisposed uniformly. And this is the first one is hereditary non-polyposis colon cancer. And non-polyposis does not mean there are no polyps, because it also goes through the polyps, but it was to differentiated from number 2, which is familial adenomatous polyposis, which we know family members present with polyps diffused throughout the GI. Number 3 is actually a subtype of FAP, the Gardner syndrome, where they also have polyposis and they also present with tumors elsewhere, and cutaneous especially. And one thing which you have heard about is the adenoma carcinoma sequence. This has been found in research to be actually the pathophysiology by which cancer occurs from a polyp. Next. So this one will just show what started off as a polyp. This again is in the anorectum. And when this was biopsied, it was actually found to have CA. The initial biopsy said it was benign, which is not surprising because of what we have said in the carcinoma, depending on where the person was scoping to. This one I scoped after somebody had seen her and excised the polyp. And it grew again, and now indeed it was cancer. Now this table shows now how the risks contribute to developing CA. And you will find that majority of people who get colorectal cancer is sporadic. In other words, there is no genetic or other factor. So it comes out of the blue. It is shocking therefore, because it means it can occur in anybody in a sporadic fashion. It's the majority of it, not the genetic or the familial. It is sporadic, 75%, 3/4 of all of them. Then now, coming up next is a family history. That's why I mentioned it's important. Although it contributes only 15 to 20%. Then next comes now the genetic diseases. Even though they are talked about a lot, you can see it's only 3 to 8% who actually get it because of this genetic predisposition. And then familial adenomatous polyposis, 1%. Ulcerative colitis, 1%. Crohn's disease is even a bit less. So that is how anybody who has a cancer, those are likely, they are likely to fall in any of that, more likely to be sporadic. The pathogenesis is actually thought to be interaction of environmental and genetic factors. So it's a multifactorial thing. And the dietary factors is thought to, the pathogenesis with diet is that they are supposed, they are hypothesized to be pro-oxidants. For example, the iron in the red meat. And this causes formation of free radicals when digestion occurs. And then these free radicals cause mucosal damage. And then this, the process of repair and so on, will lead to cancer. Mutations play a key in transformation of a benign thing to a cancerous thing. And these are through one of three mechanisms, either through abnormalities in signaling pathways, like the APC gene, you have heard about it, adenomatous polyposis coli gene. So if mutation occurs in this gene, then there is abnormality in the signaling, cell signaling. Then others are thought to be presence of oncogenes, for example, the KRAS, or through the mutations occurring in tumor suppressor genes. And this is where tumor growth factor beta and deletion of BCC, colon cancer gene, comes in. I will try now in the next slide and summarize the pathogenesis. Tumor occurs in either one of these 6 mechanisms. One, there may be the cells lose the need for exogenous growth signal. As you know, the DNA controls in an orderly way the way our cells proliferate or repair themselves. In cancer, there is loss of this, what I was mentioning in the previous slide, the cell signaling pathway. So a mutation occurs and there is abnormal signal, they start growing abnormally. Or 2, there is insensitivity to anti-growth signals. Yeah? So normally there will be, for example, the tumor suppressor factors. So when that occurs, there is loss of control in that aspect. Or apoptosis, the programmed cell death is evaded, so that does not happen. As you know, the body is supposed to destroy the cells when they are abnormal, supposed to die off naturally. And then the 4th mechanism in pathogenesis is a limitless replicative potential. Number 5 is sustained angiogenesis. And the last one is the new ability to invade and metastasize. So these are the 6 mechanisms through which all these factors produce carcinogenesis. So the famous adenoma to carcinoma sequence. So starting from the left, that is how the normal epithelium is supposed to look like. You can see. And then the next one, when the mutations occur in the adenomatous polyposis coli gene, then you have abnormal proliferation. In other words, now there is loss of the normal controlling signaling pathways. So you see there is abnormal proliferation. And then the control KRAS mutation causes an adenoma. Then you may have now activated colorectal cancer mutation, the adenoma proliferates, and then more mutations in the controlling genes causes conversion of that to a carcinoma. So this is a question how normal epithelium, adenomatous epithelium, and then becomes a carcinomatous epithelium. How does the disease spread? It's either local or distant. And you will see later that treatment has to address all these factors. In colorectal cancer, lymphatic spread is more important than hematogenous spread. And we will see the importance of this when it comes actually to operation, either surgical or otherwise for the disease. Then you have transperitoneal spread. And this is fairly common. In fact, they say that the disease, colorectal disease, usually doesn't spread much proximo-distally. You may find the tumor may be just about 2 centimeter size, for example, but it tends to spread more laterally. And this could be the transperitoneal spread or signal, so that you have tumor spread to the ovaries, for example, or the other regions. This is where they say it's like it's spreading from one locality, anatomical locality, to within the same cavity. And when this is widespread, within the abdomen, it's called carcinomatosis. So often we go in and we cannot know where the primary was because it's everywhere. Colorectal cancer usually spreads to the liver and the lungs. It's rare, although it can spread to the brain, to the bones, and other areas, but it is rare. But these two organs are of prime importance. So they say when you are targeting the when there is concerns or cost of targeting the disease or to look for meds, then you don't have to worry in other areas, provided you pay attention to these two. Now, the signs and symptoms, like I said at the beginning, it's a disease with varied presentation depending on which sub-anatomic area you are looking at. So that rectal colon C on the left side of the colon really presents differently from the right side, and also differently from the anorectal or rectal disease. On the left side, often, so we are talking on the left side, we are talking on the left half of the transverse colon, the descending colon, the sigmoid, and now the rectum we'll mention later. So on the left colon, excluding the rectum, they will present with a change in bowel habits. And this is why we often ask, you have constipation, and there are times you have diarrhea. So this is a prime thing. And then they will also present with the parectal leads. And this may have mucus in it. So it helps if they talk of blood is good to ask whether it was also mucoid. And they will also present with abdominal polyps. And this is because the tumors on the left, and especially as you come towards the rectum, they tend to obstruct area than tumors on the right side. On the right, they present with anemia. This is because the tumor is able to, as you know, the right side of the colon, the cecum ascending colon, they are wider than the left. And it can really accommodate a big mass before symptoms occur. So they often present with anemia and the accompanying signs, which is weakness. So somebody will come say they are just feeling weak, lack of energy. They may come with their overt symptoms, palpitations, shortness of breath. And the other feature, also common, is weight loss, again because of the tumor metabolism. And not uncommon, in fact, you see them presenting with an abdominal mass. Because again, the lumen of the colon, because like we mentioned, the tumor tends to grow more with your artery. So the mass really spreads, and you can anytime palpate a tumor of the cecum and ascending colon. On the rectum, the main feature is often a change in bowel habits, but the characteristic thing with this is that now people will come and say, I've started getting diarrhea, or those stools which are not going away. So in fact, many come and tell us they have been treated for amyloidosis, especially because amoeba will be fairly common in our sector. And also the labs quite often want to give you something. So many have been treated for amoeba when it is in fact correct. And mucoid stools are very common feature in the rectal CA. And another thing is fecal urgency. They feel like if they don't reach the toilet soon enough, the stools will come out. And this is combined with the next one, tenesmus, a feeling of incomplete empty. So they felt the urge to rush and they have to leave themselves. And then they feel as if things have not improved. And you remember they also have some diarrhea. So in fact, many are treated for infective causes. They also may have pelvic, perineal, or perianal pain, or anal pain. Some people do say pain behind there. Of course, there are many other benign conditions which cause pain. When this occurs and it's not unusual, then it's a late presentation. What I have not presented here is especially low-lying tumors, especially anorectal. Patients will come having had surgery for hemorrhoids. And this is fairly common, even in our setup here. I've seen several. So there are other presentations. People may come with perianal abscess, because of the drainage. I didn't go into the anatomy, the blood and vascular supply, but all tumors will spread often, like he asked about the groin nose. So it's important when you see some perianal or anal symptom, indeed, like we mentioned shortly, that you send them to look a bit higher. So the diagnosis, as in many diseases, from history and exam, and the physical exam in this case must include a DRE. Remember the adage, you must stick your finger there. If you don't have your finger, you have a finger, you have to stick a foot. They were trying to see how important it is. And because you can, many of them, especially the colorectal and anorectal, you can actually diagnose them with a finger. Not uncommon it is to have people come, like you mentioned, with the symptoms or GI. And nobody has ever done that with a finger. But you put it, now the tumor is advanced. Indeed, the left, the lower, especially the lower colorectal tumor, they tend to present only as differential. Unlike the left colon, where the tumor may be eccentric on the, and on the right colon. On the left colon, tumors tend to be differential. Now, so after history, physical exam, the next thing is the colonic exam. And the first thing in colonic exam is endoscopy, which is one of the 3 or 4. The first one is anoscopy, proctoscopy, which everybody can do with a speculum. After that, then we have sigmoidoscopy. Sigmoidoscopy, you know, will reach up to the level of the sigmoid. If we have extended sigmoidoscopy, we reach the spreading flexion. So we will show you only just about the left colon and the rectum and the anus. But colonoscopy is actually the main investigation. And why is it so? Because not only will it be diagnostic, but also you can be able to take a biopsy. And indeed, when you get polyps, you will remove them. Because of, remember, adenoma, carcinoma sequence. So it is the number one indicated mode of exam. The only thing about it, of course, is that it's the cost, because it has to be done appropriately. The other thing is the learning curve, which is long. Not many people can be able to do it. The other thing to note is that about 10% of cases, even an experienced endoscopist will not reach the seeker. But the aim is always to do a complete colonoscopy to reach the seeker. At times, we also may look into the terminal eye, which is possible through colonoscopy. The other ones, double contrast barrier minima. This is useful where there are no services for colonoscopy are not available. So the double contrast, rather than the so-called barrier minima, is able to show more details. And especially the next one, CT choreography. So it's a CT scan for which there is contrast in the pathology. It's able to show more. But we are saying the limitation is that it's only the diagnostic. The other thing about double contrast barrier minima is that they have been found to miss even 20% of tumors. So it's really not something which we want to use in a setup like ours, where endoscopy services are available. Blood investigations is the next armamentarium in the worker. And this will include the hemogram, the UEC, the LFTs, and CEA level. Of course, not only will they help in the pre-optimization, but like we said, some of the patients may present with severe anemia, and even the treatment planning will be key. The CEA level, as you had in this patient, was normal. Let's go to the next one. I mentioned about CEA later. So, after this diagnostic worker, then they are so-called staging. Because before treatment, you have to stage every tumor. And the staging investigations are both for the local disease and to look for eggs. Always, these two should be done before treatment. So for local disease staging, for the colon, CT scan suffices. I don't see a CT scan, despite the hype about the MRI, is really the method of choice for colon cancer. And this is because with MRI requires still tissues in order to define the brain very well. But as you know, the intestines are always on the move. So it's very good as an investigation. So the CT scan is still the primary imaging for analyzing the stage of colon cancer. When you come to the rectum, however, things are different. Endoano or endoscopic ultrasound is actually at times have been said to be even better than MRI. Now in the rectum, MRI supersedes CT scan because it's able to show the tissue plate much better. And like you mentioned, when you come to the surgery in the rectal disease, you have to eliminate the local disease if you really want to be cure that person. So you have to see where the disease has reached. If it has reached the other stage that you mentioned, then you will give neoadjuvant treatment to the stage. And the one ultrasound has only come to Kenya recently, so the expertise is only limited at the moment, but it is found to be equivalent in good hands to actually MRI. In fact, at times they say it is superior. And the other thing with the one ultrasound is actually you can do a guided biopsy with a probe there, so it is quite good in experienced hands. For the metastasis, then you do CT scan of the chest because we say metastasis to the liver or to the lung. So CT scan, they also do chest X-ray at the same time. And then for the abdomen and the pelvis, CT scan again will show meds better. But if you are staging with a rectal, then MRI is indicated. Liver ultrasound in good hands. Ultrasound again, I think, is becoming, again, there has been a new height. It actually has enormous potential for helping in management of patients in good hands. So liver ultrasound, they can be able to pick very small tumors as well. Plus or minus MRI, like we say, if it's the rectal, you want to stage it in the rectum. Now, what about detection of or detecting recurrence? This is part of staging now in recurrence. Then you repeat the scan. You may do MRI, like we are saying, for the pelvis and the rectum. And then there is something called a PET CT. As you know, PET scan, again, there has been a hype. But a PET scan may be good to show the initial meds, but it's very poor in so-called partial differentiation. So it may show you there is a tumor somewhere, but it will not show you the planes where you are planning surgical to go. And that is why they add there PET CT. That enhances now the use of the PET scan in order not only to recognize them, but actually show how they are anatomically related, and therefore you may practice from treatment. Now, having said that, before I go to treatment, I thought it's good to mention screening because of what we mentioned. 75% is human sporadic, and then we have the familial, the genetic. So screening, therefore, and in view of the high mortality, you are having that 75% of patients dying every year, then screening will be useful. And these are the four things which the American Cancer Society has recently said are useful. Before then, we used to have number 2, but the number 1 has come in, which is called multi-target stool DNA. This is where they take somebody's stool and they do DNA studies on it. They look for markers in the stool. It's been found to be very quite useful. It's like the genetic studies in TB, for example. It's equivalent like doing genetic studies on spiritual and so on. And this has been recommended to be done here. This is an overall thing that I'll mention in another slide shortly, how nowadays timings can change depending on The next is a free cohort blood test. This has been with us for many years, and you know there are two types. There is the wire-based and there is the or the chemical-based. This should be done annually or every 2 years if you want to screen. I will talk about the age of screening shortly. Sigmoidoscopy should be done 5 years. So if somebody had a tumor on the left and you want to screen the members of the family, like I mentioned before, it's better to do the next one, which is colonoscopy, because to show you both the left colon as well as the right colon. And synchronous tumors are not unusual to find. So one may have a tumor on the left and a tumor on the right. So indeed, if one finds a tumor on the left, it doesn't mean now you start preparing for surgery. Should look for tumor on the right as well. So colonoscopy is more advisable and should be done 5 to 10 years. Now, the screening age, when you begin, and this is, I try to summarize this table, so that on the left is the risk category, and on the right is when to begin. So if it is average risk, in other words, there is no family history, there is no cancer, gene cancer in the family, then you start at 50 years, because like we say, it's cancer of age. Then like we said now, the tests you do are the ones I mentioned in the previous slide. So for anybody, any person out there, then we should tell them if they have not had a colonoscopy at 50, then they are doing poor as far as screening themselves for colorectal is concerned. If there is a family history, however, then the age comes down. You want to start screening 10 years younger, than the average population, or 10 years younger than the member of the family who was affected. So it's close to breast cancer. Indeed, we say breast and they are related. There is shared characteristics. So if a member of the family died of CA colon at 40, then you want to screen the members of that family from that, at least 30 years, 10 years earlier. For hereditary and for post colon cancer, because it is an autosomal dominant condition, so indeed it will affect all the members there. Even if not all of them may develop it because of clinical penetrance, but they are all predisposed. So for this one, you start even early. You start at 21 years. For the other one, familial adenomatous polyposis, you start even earlier. You start at puberty because they have this polyps there from a very young age. They will eventually develop to cancer. So you start screening them much earlier. For the inflammatory bowel disease, especially ulcerative colitis, the time you diagnose them, to be having pancreatitis means colitis of the entire colon, then you want to be doing it every 7 to 8 years. However, if the diagnosis is limited only on the left side, for ulcerative colitis, the worst disease usually is the sickle. Out there. Therefore, we are talking on the right colon. So you need to be more aggressive with that one. But if it's on the left, then they don't have to be. So if you start screening them, 15 years after you diagnose that, see, now we are talking screening for CA. Staging, what has been used often is the dukes before. It's still useful, but nowadays it's encouraged to use TNM. And why TNM? Because it will give you prognostic data, and the treatment is actually tailored to, depending on the work status, especially. So it's more encouraged to use the TNM. Now, this slide channeled very well, but I wanted to show the basic tenets of the TNM. T1 are really mucosa tumors. So ones which have not reached the submucosa. The submucosa is so the mucosa is on is a point line. When tumor reaches the submucosa, it goes to the it touches the muscularis without going through it, then it's a T2 tumor. So it's quite simple. And then when it goes through the muscularis to the serosa, now that is T3. And T4 has invaded the surrounding organ. This is as far as the local disease is concerned. Then after that, of course, is the nodes. And nodes can be N0, where there are no nodes, N1, which is the peri-tissue node, so the perirectum, the pericordium, and then the N2, the second line nodes. And then, of course, M, M0 where there are no meds, and M where there are meds. Now, the stages, clinical stages, combine the T's and the N's and the M's, so that you have stage 1 disease, which is disease which has no nodes and organs. That is T1. I mean stage 1. Now, stage 2. So, stage 1 is limited to the mucosa or muscularis. It has not gone through the muscularis. Now, stage 2, now the tumor has gone through the muscularis, but there are no nodes again, and there are no meds. So these are just sub-staging. 2A is when it has not gone through the serosa, and T4 it has gone through the serosa. Stage 3 now is when you have nodes. So somebody who has nodes, like in the case which was presented already, you saw it was stage 3 because the scar showed perirectal nodes. And it is subdivided into A, B, C, again depending on which nodes we are talking about, whether it's the pericordic, perirectal nodes, or the ones which are further along. And then of course stage 4 when they are meds. Now, here I presented a table from the American Cancer Study which showed in one of the studies the presentation of patients. And so therefore it's not a disease of ourselves where people come late, even out there. They still go late despite all the hype and awareness. So for those in the US, for those who presented with localized disease, there were arrests, 38 and 34. And then the other ones, the next two showed disease which had advanced. So you can see it's actually the majority. Yeah. And they say it was worse for the African Americans, so we carry our bad mentality even out there. We stick with our disease, we present it late. So it is actually even something which I saw in the study I did for the upper GI tumors. Even patients, even out there, even here, they still present with advanced disease. Now, staging, like you mentioned, reflects the outcome. So it has a prognostic importance. Now, what about so there was the local disease staging. What about the histological staging? You know, there is well differentiated, moderately differentiated, and poorly differentiated. The poorly differentiated have a worse prognosis. Then you often see the pathologists talk about music producing or non-music producing. If it's music producing, then it has a better prognosis. You will also see them talking about signet ring or ones without signet ring. The ones with a signet ring have a worse prognosis. Now, what about the lymph nodes? When the surgeon goes to operate, just like in the breast, they should come out with as many nodes as possible. This has two important things, because one, like you mentioned, the hepatic spread is the main mode of spread. So when you come out with all the nodes affected, then you are reducing the recurrence of local chances of local recurrence. And then, of course, number two is that will help in staging, like we mentioned, whether it's N1, N2 is important. And when the pathologist looks at the stage, that's when you have the PT, whatever. In this case, the patient will show there was only a difference between the clinical and the pathologic staging in the node status. So if somebody has not come out with 13 nodes, then they cannot do a good job inside there. Yeah, so some will mention that 13, others will mention 15. There should be at least 13. And the important thing is that, unlike in the breast, where the more you go for nodes, the more you harm the patient by the edema. For colorectal cancer, it's not been found that you are doing more harm to the patient. It doesn't increase the morbidity. So actually, it's good to go for as many nodes as possible. Now, the role of CEA. CEA is a glycoprotein and it's absent in normal cells. However, in the colorectal cancer, it is present in 97%. So there are 3% who will not have elevated CEA. So a normal CEA does not rule out. In the presence of a mass, does not rule out. And in the next sentence, we will therefore mention that we don't use CEA for screening. But I did mention it therefore in the screening things. So I only lost for it. It's not used for screening. Now, when it is present, the increase correlates with either disease that has metastasized to the liver or the size of the tumor. So if there is a positive CEA, in other words, if it is more than 4, then it implies the higher it is, it means either the tumor is much larger or it has metastasis. Now, why don't we use it for screening, other than the fact that 3% don't have it? Is because of the next point, that patients with disease confined to the colonic, mucosa or submucosa. So we are talking about T1, T2 disease. But to 40% of them don't have a elevated CEA, and yet they have tumor, which is potentially curative. This therefore negates the use of CEA as a screening tool. So they use that as a follow-up tool. So that if you treat the patient, the CEA comes down to normal, then in the follow-up, if you notice it is rising again, then you know there is original recurrence or metastasis are coming. Now, treatment. Surgery alone is a cure. Yeah? Stage 1 disease. So you remember the stage 1 we talked about. Surgery alone is curative. What about stage 2? Stage 2 now, there will be some debate of whether you, but this should be done in conjunction with the patient, in conjunction with the oncologist. But for T1, especially people who come with malignant pedunculated polyps, I didn't have time to bring the polyps and the chances of CA in them. But for the pedunculated polyps, if the tumor is found to be on the tip, so when you remove it, the pathologist will section it. If it's just localized to the tip of the polyp, then the chances of that is really stage 1 disease, and they do not need any other treatment. If you are good for the other polyps, the selected one, so then the things may change. Now, what about margins? Margins, like we mentioned, spread is mostly mediorectal, not proximal distal. So in surgery, you only want to achieve 5 centimeters. So for a patient, and maybe you critique the surgery which was done here, you should aim for a margin of 5 centimeters. So if from the anovulge, the tumor, you want to retain the sphincter, the anatomical sphincter is cervical sphincter is actually up to about 4 centimeters, that we colorectal muscle. So, and you say you want to retain 5 centimeters. So it means if it's at 4 centimeters and you want to do anastomosis, then you should be above 4 centimeters. So let's say you give 2 centimeters and 6. Then it means your margin, remember we say this 5. Or let's say you just have a margin of 5. Then you have 5 and 10. So if this tumor is less than 10, for example, and you have not done your adjuvant therapy, it means therefore you cannot do sphincter sparing surgery. That's where the importance of this margins comes in. Your adjuvant helps for you to save the sphincter if there is good response. Now, the other thing is circumferential margins, which we mentioned are more important. And this has importance, especially in preventing of original current. more so in the rectum. Because if you don't achieve this, they will soon come with regional recurrence, which will be very difficult to treat. So positive circumferential margins rectal cancer are associated with local recurrence rate as high as 85%. And for the rectum, we talk about total mesorectal excision. So we have to achieve total mesorectal excision, removing the tissues around the rectum. In colon cancer, however, the margins are less, they are less important, except with the exception of T4 tumors. Yeah? T4 tumors now are spread beyond the serosa. But still it's not a lost cause. Indeed, we have operated patients where the tumor is attached to the duodenum. You remove part of the duodenum. This is what is recommended, and it's called en bloc dissection. It's been found to still have a survival advantage. Next.
Could you explain a little more the circumferential?
The spread from the lumen, the spread outwards. That is what is most important for colorectal tumor. Proximal distal spread has been found to be very beyond 2 centimeters. Yes, so of importance is the lateral spread. For the rectum, you have to get the mesorectum out. If you have initial staging, the mesorectum is involved, then you are safe. You cannot give up, or you have to give neoadjuvant to downstage in order for you to do a good job. Otherwise, if you are going to leave tumor, recurrence will inevitably occur. It will be difficult to treat. However, for the colon, it's spreading in that even when it spreads to the adjacent tissue, you can do control resection without giving the patient. And often it's possible. Patient may come with a very huge mass there, but you can be able to surgically excise. That is what is recommended. It has a survival advantage. Now, yes, let's go on. In colon cancer, because we say that the main thing is vascular spread, then you have to get the effect. And I will show some diagrams shortly. Next. So this one shows the tumor of the right colon. So you can see single tumor, ascending colon tumor. Then this is what you do, what we call right hemicolectomy. You go for the transverse colon, about the middle, and then the terminal area will set there, and then you join the rest. And this is the standard treatment for right colon cancer. For left colon cancer, next, then this is what you do. So you have tumor in the descending colon or in the sigmoid colon, then that is what you remove. It's almost like the other one. And now you are removing the remaining part, and you are leaving the cuff of the rectum. That's where you join now the transverse colon to the rectum, called colorectal anastomosis. For rectal tumors, this is what you do. And the picture is showing the correct dissection, because this is the mesorectal tissue, the ones on the side. And one always, whenever you are going for rectal surgery, you have to remove those. So if you have not removed them properly, like shown on the right, then that is the wrong thing, and disease will inevitably return. The next one also tries to show mesorectal, total mesorectal excision. We say the lymphovascular spread, so therefore you come with the vessels, the superior rectal or superior hemorrhoidal artery, you have to get it. You don't have to ligate the inferior mesenteric, except if there are still nodes there, then you may need to do that. So on the rectum, so you remove that, and you remove that in order to remove the nodes. Yeah? So somebody may have a high rectal tumor. You have to remove the sigmoid. The sigmoid has to come out in the rectal tumor. The next one also tries to show, of course now see the rectum, because again the rectum has 3 parts, the upper, middle, and inferior, and the drainage, the vascular drainage is a bit different. Therefore it has slight variations, but this slide just tries to show 3 things. Tumor is in the upper right, those are things to do on the left. And there, neoadjuvant For early tumor, there's something we are called TDM, which is anal endoscopic resection. And indeed, like we say, you can do this if it's a polypoid tumor. Now, for early tumors in the rectum, even the lower rectum, you can do endoscopic surgery if it is mucosal, or you can do also open surgery in T1 and T2 tumors. You can do surgery through the rectum and spare the sphincter. But now, the treatment is typically summarized. If it's a T3 tumor, you have to do more chemoradiotherapy. Now, what are the other considerations? The role of DXT colon cancer, anybody? What's the role of radiotherapy in colon cancer? Does it have any role? Yes, no? Yes. Which role? It's limited, a very limited role, if any, in colon cancer. It's chemotherapy. There are also some talks at the time of immunotherapy, but surgery and chemo are the main things. What about neoadjuvant and DXT in rectal cancer? Like I mentioned, you use this to downgrade the tumor so that you can be able to safely resect, yeah? And you can spare a sphincter in somebody who you may not have wanted to do that. The only thing about these two is that you need to give them like radiotherapy. They say you give it in the 10 days before surgery. But our limitation is people, you tell them you need neoadjuvant chemo, they say they go look for money. They get two days and they say the money is finished. So those are our limitations. Otherwise, the thing with radiotherapy is when you radiate and you take too long, that will be fibrosis. You won't be able to operate well. So they say it to be done well 10 days, and then you go in. Of course, in stage 4 disease, it's palliative care. Palliative care may not mean no surgery. It means surgery or other interventions which improve the quality of life of the patient. Yeah? So if they're having severe pain, you can go in and without that, and they get the advanced palliative chemoradio, then that is okay. Or it creates trauma so that they stop having obstruction and so on. What about the role of pre-mechanical bowel prep? Anybody? Bowel preparation before surgery? It's controversial. Yeah? Although the thing is that yes, there should be some form of bowel prep. However, studies have not shown that there is any difference in outcome. In other words, it doesn't increase the rate of sepsis, whether you are operating with corroded bowel or not. Of course, the comfort theater is more when you have yes, but it doesn't affect the The other thing is that if somebody is having a laparoscopic procedure, then the mechanical bowel prep is the high volume, the peglex, and so it's very good because the gut will have collapsed. But if you have the corroded colon, you will be fighting that return at laparoscopy. So, some form of preparation is good. Yeah? Whether you do this or that doesn't really impair on the outcome. What about pharmacological bowel prep? Yes, you have to give that. Because mechanical bowel prep has not been found to reduce the microbial load. Even if you give 20 peglex, the microbes will still be there. So you have to give pharmacological preparation, especially the oral ones, in order to clear the microbiome. That does reduce post-op sepsis. Transfusion. Should you transfuse, should you not?
It depends.
Yes? Yes?
Depends on the status.
What level do you transfuse? Actually, you avoid transfusion as much as possible. If the patient will survive surgery, even with a HB of 8, don't transfuse because of immunodepression. When you transfuse, you are immunodepressing the patient. Yeah, so you only transfuse really if the patient is not will not be able to survive anesthesia. Emergency surgery, primary anastomosis, should it be done, should it be not? When Major was in medical school, he was told, to find obstruction, you have to do that. So now the mentality has changed. The fact that you can save it, because of the studies we are talking about with bowel pressure, we found it is safe to do a primary anastomosis. The only thing which our professors still have given way to is they say it has to be an experienced hand. Otherwise, it is doable. It is encouraged. It has scientific backing. Synchronous tumors, I mentioned, you should not forget. So if you see, if the scope can't go beyond what you are seeing, it doesn't mean it's not tumor. You still have to stay with the disease. DVT prophylaxis, yes, it has to be given very low. Now, somebody comes with a severe rectum or colorectal and has some primary disease. You say this is stage 4 disease, you can't do anything. No. Yeah. So if there is, you do the primary resection or the metastatic lesion and a curative resection of the cancer primary. This has been shown to have a positive survival outcome. They stay in stage 1, survival, 5-year survival is 100%. As you go down the stage, survival of course reduces. So that somebody with stage 4 has about 5% 5-year survival. But it's been found when you do this, you actually improve your survival to even 45%. So it's not a lost cause that used to be lost. That if somebody has a met, that's the end of it. Unless it's really notified. And so in this slide I'll show one of the questions. We have operated recently, had two meds, which were fairly well completed. And so we did anterior resection and also resected. This was in segment 2 and 3, that is the left lobe of the liver, the apex, you know, the triangular part. And then this was in the, we call it segment 6, the right lower part of the liver. So this patient is did well. We also removed the primary, now he has going for chemo. There is a scan showing where the tumor went on the left lobe. The scan didn't show this, but this was because it was segment 6. So that was shown in another time. That two patients recently, and they did very well. Primary section and removal, segmental section of the liver.